Hey, how's it going, guys? How's everyone doing today?
Good. How are you?
Good. Good. Finally got all your clinical schedules out yesterday.
Oh, we were so stoked.
Good.
I feel we were just on the tail end of Derek's class, and everyone was just like sitting there wide-eyed and watching him land. It was cool.
Good.
We're all very excited
Good.
and scared, but mostly excited.
It's totally understandable to be scared. So hopefully by the end of this class and pediatrics, we'll feel a little more at ease.
Yeah, there's a lot more PPD checkout forms in this course than the last one.
Yes. Yes, they are. You guys will be okay. You'll get through it.
Oh yeah. We got this.
This is a fun course because you really start to do things that you're going to be doing as an RT rather than just all theory.
Right. Yeah, the last therapeutics was a lot of theory and even pharmacology and diagnostics. Diagnostics is some like doing the PFDs, but a lot more theory with Derek.
Yes. I had Derek as an instructor too, so I understand how intimidating he can be at times.
He's just a lung nerd. I was intimidated like the first time going through his case studies and coursework stuff, but it was like, nah, you just really like this stuff. Okay. Okay, man. For the sign up genius stuff, do you want us waiting to do that, or if we just knock them all out now since the forms are there, is that okay?
Yep, that's why I put him up so you guys could have plenty of time to figure out what dates you wanted to come in.
Sweet.
It's just 2 of them, right?
I'll go through, I'll show you where the other links are for the rest of the labs.
Okay.
Give everyone another minute or so.
I don't know if this was mentioned already or not, but when I click on the Humidity Lab sign up, it just says it's refusing to connect. I don't know if anyone else is having that as well.
I just had to open it in like a different link, and I'm sure Stacy will show us, but there's another part where like there's all the links that for the sign up geniuses, and that took me there a little bit better than the other one.
Yeah, and if
Perfect.
that doesn't work, just shoot me an email and I'll email you the link directly too.
Perfect. Thank you.
You're welcome. Okay, so let's get started and we'll go through the basics, the syllabus, calendar. So we'll start with that. Okay, so on Blackboard, I'll show you the sign up link. So in the resource folder, I have all the documents that we're going to go over as well for your reference. All the PPD checkoffs for all of the different things that we are going to be learning are in the PPD checkoff folder. And then whatever Zoom recordings we have after live lectures, I'll put in the Zoom recording folder. It does take a while because it has to download to my computer and process, and then I upload it to YouTube so you can see it. So it won't be right after we end a lecture. And then here we have all the Sign Up Genius links. So Humidity, our aerosol drug lab, CPT, PEP, and then section trach care. So this one, Ariel, might be easier for you to use this link. It might connect better. And then if I have any other like videos or different websites for different topics, they'll be in specific folders here under resources. That way your course content doesn't get bogged down with everything, and it'll just be easier to navigate. Okay, so let's start with the syllabus. So this is our syllabus. We have 3 books for the course. So we have EGANS, which you're all familiar with, and then we have the basic clinical lab competency. So when I say basic clinical competencies, it's this book. And then equipment theory by White. And when I say White's equipment book, it's referring to this book. So you have 3 sources for information. If you are having a hard time understanding EGANS, sometimes the wording in that book is a little tenacious. So if it's not working for you and you're not understanding it, try looking at another book. Okay, so.
Tenacious, like sputum. Nice.
Yes. So how your grade is broken down. So exams are going to be worth 20%. MREs are worth 10%. And I have switched kind of to what Nicole does with MREs. So your MREs won't be timed. So you'll have plenty of time to go through them and think about them. And they're a lower percentage. And then discussion boards are worth 10%. Labs are worth 10%. Homework is worth 15%. PPS is the standard 10. And then your final exam will be worth 25% of your grade. And the breakdown of the grades are the same. And then here you have the course objectives that you can go through. Okay, so let's go over the calendar. So I wrote this calendar before I knew I was going to be the clinical director. So most of these lectures are live. I am going to have some of them recorded just because I'm going to have to get all your paperwork in for clinical sites plus the other 2 cohorts. So I have 62 students who are going out to clinicals, which is the most we've ever had. So there's going to be some days, and I'll let you know ahead of time if they're going to be live or recorded. Next Wednesday, excuse me, next Wednesday will be recorded. Marilyn has a CF clinic appointment, so that was the only one on here that's recorded, and that will remain recorded. Any questions so far? Okay.
Have you posted the calendar for us to be able to print it yet?
Yes, it is under syllabus, with the syllabus. So it would be.
You might need to make it available to us. I'm just seeing the syllabus.
Oh, it didn't go through. Okay, I will upload that. Let me make a note. Otherwise, I can forget. Okay. So let's go over PPS. So it's the same as all the other classes. The biggest ones that I find students getting dinged on quickly is attendance and leaving early or being tardy. Just open communication goes a long way with me. So let me know if you're going to be absent, if you have to leave early, or If you're running late, even if I don't reply to you and you email me, then it's documented that you let me know. Because those 5 points for not reporting an absence or tardy or leaving early add up really quick. And this is what I use to grade your PPS while you're at clinicals. So if you're late to a clinical shift and you don't tell me, even if it's just an email saying, hey, I was running late, there was traffic, I will dock you the 5 points. And then full uniform. So on campus, just make sure you're wearing your scrubs. Your tattoos can be showing on campus, but when you're at clinical sites, you cannot have your tattoos showing. And then unprofessional communication behavior. So just open communication, professional. Not following school policy would be a 2-point deduction. So if you have fake nails, you should have them taken off because that is a school policy and that's part of our dress code as well. And then like this is all at teacher's discretion. So, you know, if something happens once, maybe twice, we kind of tend to let things slide, but just be aware of what you're doing. Okay, so discussion board rubric. This is in our resource folder. So the discussion board rubric is what I use. I pull this up when I grade discussion boards. And this is how the points are broken down. So timeliness, discussion boards cannot be accepted late because then you're not, participating in that discussion. And there's not going to be enough time for your classmates to respond to you if you ask questions. So make sure that you're checking the discussion board so that you are also responding to questions that are asked of you. Okay, and last one here is our writing levels. So in my assignments, and I'll pull up the humidity brochure here in a minute so you can see an example. I include writing levels. And so this is from PIMA online programs. So if you go to do your bachelor's through PIMA, you'll already be familiar with this and be comfortable with these writing levels. So we're setting you up for success. I don't know if any of the other instructors use this or if I'm the only one, but we have level one.
Yeah, our micro and you was the only time we've been introduced to this stuff.
We have level one,
With
level
Gina,
two.
we did too.
Gina did too? Okay, good. And level three, we don't have any level three papers in this class, but I know Justin loves to assign APA formatted papers. So just be aware he's teaching pediatrics, so that might be coming up. The biggest thing here is in level one, avoid using contractions and personal pronouns. There are a couple assignments where I ask for your opinion. So if I'm asking for your opinion, obviously you can use personal pronouns. Okay, so let's go back to Blackboard. So our late policy is on the very top of course content. So any written assignments and MREs will be accepted up to 72 hours past the deadline for a 10% per day reduction in grade. So it's really easy to get behind we have a lot of assignments going on. I know, Derek, are you still in diagnostics or diseases? Diagnostics. So I know it's easy to forget due dates. So I try to post due dates on the daily announcement on our course content folders here. It'll tell you the due date. And then also, I'm a big fan of, tell me if you can see this Word document. Can you see it?
No, but it's the what to expect, right?
Yeah, the what to expect. So I live by those and update those frequently. So those will have due dates as well.
It was pretty easily downloadable and I can see it, but I can't see it on Zoom.
So what to expect. So I'll post those to go with every week. So those are going to be more reliable for you than the calendar. The calendar will have the dates and the topics, but the what to expect are going to tell you what we'll be doing that day and what's due that day, and then any readings that will correspond with it. Okay, so final assignments, which we don't have a project, we're just going to have a final exam. Labs, so lab days and discussion board assignments cannot be made up. So those are not going to fall in the late policy. I've created a class discussion board. This is for you guys. It's not graded. I might pop in there every once in a while just to see if there's any questions I need to clarify or any topics, but this is for you guys to talk with each other. I don't know if you have a group chat that works better, but it's there if you need it. Or if you want to post examples of assignments, or you've created a study guide that works really well for you that you want to share with your classmates, you can upload it there. Okay, and then last, I want to kind of go over, switch gears for a second and talk about clinicals. So Mary, is it okay if I share your clinical schedule for, okay. So I have Mary's pulled up. So this is kind of what your guys' calendar looks like, right? When I schedule shifts for you?
Right. Yeah.
Okay. So something that I want to point out that is very important is it will have your shift times up here. Now, for those of you, everyone has a day at Good Samaritan doing PFTs, and everyone has 2 days at pulmonary rehab at Lutheran. Now, for those of you that are doing regular clinical shifts at Good Samaritan or Lutheran, make sure that you check to make sure it doesn't say pulmonary rehab or PFT. So Mary's going to Lutheran also. So here it says days. So make sure you check, and that will tell you the right shift time. So days, and then back here it says pulmonary rehab. So their times vary a little bit. Okay. Any questions on introduction to the course? Okay. So with me, something to know before we get started is always know your goals. So if I mention the goal of humidity therapy is to maintain normal physiological conditions, know the goals, always know your normals, your indications and contraindications. So those are all big points to know. Okay, so let's get started with humidity and bland aerosol therapy. If you guys need a break before I give you a break, just let me know. Sometimes the chat doesn't pop up on my screen, so if you have a question and I don't answer it right away, just stop me and you can ask questions.
And do we have access to this PowerPoint? I didn't see it when I looked in there.
Let's see, let me look.
Yeah, it's under course content for day one because I printed mine out.
Okay,
Thank you.
yeah, it's next to attached files. Okay, so the body is going to naturally humidify.
Hey, Stacy, just really quick, Destiny is bopping in and out. She's having troubles with her Wi-Fi.
Okay, thank you for letting me know. And I am recording, so this will be available too.
And one quick question, we don't have anything that's due today, correct?
Correct. You are good. Okay, so the goal of humidity therapy is to maintain normal physiological conditions. So our body is naturally going to heat and moisturize the air that we breathe in. So if that is taken away from us, our goal is to provide that therapy that is going to make up for the body's inability to heat and moisturize the air. So the upper airway, the nose, is going to heat and humidify gas on inspiration so that as the air travels down to the lungs, it's already the proper heat or the proper temperature, sorry, and holds enough humidity that it's not going to do airway damage. As we exhale, that air is going to cool off and the upper airway is going to take the moisture back out of that gas. So BTPS conditions. So know these conditions, what they are, and what BTPS stands for. So body temperature. The upper airway is going to heat that air, that gas, to the body's internal temperature of 37 degrees by the time it travels down the airway. Pressure refers to barometric pressure. So what's barometric pressure in Denver?
Like 640.
640.
Good. What about sea level?
760.
760.
Good job. And then saturation, by the time the gas travels down to the lungs, it should be saturated with water vapor at 100% relative humidity at 37 degrees Celsius. And we will go over relative humidity in a couple slides. So as the gas travels from the nose down to the lower airways, as it travels, it's going to gain all of those conditions. It's going to be heated to 37 degrees Celsius, and the relative humidity is going to reach 100%. So the isothermic boundary, you're going to need to know that. The isothermic boundary, oh geez, sorry, or the ISB is 5 centimeters below the carina. And once it hits the ISB, it's at that point that all of the BTPS conditions are being achieved. Okay, so inspired air is variable in temperature and humidity. So our humidity here is going to be very different from humidity in Louisiana, right? It's super dry in Colorado, whereas somewhere like Louisiana is much more humid. So our body is going to have to make up for that deficit. So why would the mouth be less effective than the nose at heating and humidifying?
It's a bigger area,
Yep, bigger
larger
area.
cavity.
Yep, and it loses heat faster. Okay, so here we have the nose. So the nose heats and humidifies gas on inspiration due to turbulent flow. Let's see if it will let me draw for you. So if air just went in like this, we have laminar flow. So it's not going to touch the mucosa as much, be in contact with it. So we have the turbulent flow. So it gives more of an opportunity for that gas to come into contact with that moist, warm mucosa. And that's how the gas is going to be heated and humidified. So turbulent flow increases contact. Okay, know that. So on expiration, you still have that same turbulent flow, and that is going to give it more opportunity for the nasal mucosa to cool the air and regain the moisture. So that way our mucosa is not drying out. Does that make sense? So above the ISB. So where is the ISB? Who remembers?
5
The iso-
centimeters below the carina.
Yep, 5 centimeters below the carina. So anywhere above the ISB, temperature and relative humidity decrease during inspiration. It's going to decrease during inspiration and increase during exhalation, because if that air has not hit the ISB yet, it's not to those BTPS standards. It's not warm enough for the airways, and it does not have enough moisture yet. But once it hits the ISB during exhalation, it's already been warmed and humidified. So it already has enough moisture and the temperature is accurate. So it increases during exhalation. Below the ISB, temperature and relative humidity remain constant. So that's saying that anywhere below 5 centimeters below the carina, that gas is going to have the proper BTPS conditions, that it's not going to cause airway damage, right? So it's going to be 37 degrees, so it's going to be body temperature, and it's going to be 100% humidified. And this is all naturally. So our body does this with every breath. So the ISB shifts distally, so it goes further when a person breathes cold, dry air, because the body is having to compensate for the cold and the dryness. So if it's, when you walk outside and it's really cold and you come from inside where it's really warm and you kind of get that gasp, it's the body saying, okay, I have to warm this air further. Or putting a scarf around your mouth is going to help keep that ISB where it needs to be.
Is there a limit to where that shift can go depending on like cold air? Because I know like at a certain point you're going to start doing damage and getting deep into the lungs for the ISB.
That's a good question. I don't know if it's like a physical location or if it's maybe an amount of time that could make it worse if you're exposed to colder air. Because then if your body can't humidify and heat that air, you're also going to affect your core body temperature as well.
Right.
Great question. If the airway is bypassed, so if we are intubating someone and they have an endotracheal tube and we're completely bypassing their upper airway, so we have to add humidity to that because we're taking away their body's natural abilities. So if minute ventilation is higher than normal, why might that shift the ISB distally?
Breathing faster?
Breathing
Yeah,
faster?
breathing too fast for it to get warmed up and humidified.
Good. Yep, exactly. So think about that diagram where I showed the turbulent flow. If we're going too fast, it's not having as much contact with the mucosa to grab the heat and moisture. So know what shifts it distally. And then we can have a shift up if a patient is either over humidified. So maybe we were bypassing their upper airway and we left the mask, the BiPAP mask on, and we didn't change the temperature of the heater. And so now we're delivering more moisture to the airway. That could shift it up. Or if there's fluid overload, which means, I don't know if you've heard that term yet. So fluid overload is they have too much fluid in their body. They're retaining fluid. Maybe they're not, they have kidney dysfunction, or they're third spacing, or they're shock, or whatever the reason is, but they're considered fluid overload. It's not going to take as much to heat and humidify the air. So with it shifting distally, we are going to need to give them humidity and heat for their air, for their gas. So we've heard relative humidity, and relative humidity is a ratio. So it's given, we have an amount of water based in a volume of gas, and it's the maximum amount that it can hold. So depending on the gas. So how much water a gas can hold versus how much it's actually holding. So it's represented as a percent. If we are measuring we want to actually know what the relative humidity is, we would obtain it using a hygrometer. So that's something, the hygrometer is something you're going to need to know for your boards. It's something we don't typically do as RTs, but that is how we would measure it. And then absolute humidity is the actual amount of gas or water in a given gas. So relative is comparing absolute humidity, and absolute humidity is how much water is given in the gas at that moment. So to tie it all together, so when we start here, we start at the upper airway, and we'll say that the temperature of that gas is 22 degrees Celsius, and relative humidity is 50%. So 50% of the gas that's going in through the nose is humidified. And then on inspiration, by the time we get back here, the temperature has reached 30 degrees. And the relative humidity has already gone up to 95% because it had that time, that turbulent flow, that it has been in contact with the mucosa. So it pulled the moisture from the nasal mucosa and the heat as well. So as you continue to go down the airway, and we hit the ISB, which is 5 centimeters below the carina, the temperature gets up to 37 degrees Celsius, and we've hit that 100% relative humidity. So you can see as we, from start to finish, as it travels, it's going to get warmer, and there's going to be a higher amount of moisture in that gas. So if we increase temperature, we're going to increase capacity for humidity. So the higher the temperature, the more moisture that that gas is going to hold. Know that concept. So relative humidity always represents how much of available capacity is saturated. So if someone is breathing cold, dry air, or maybe they're breathing through their mouth because they've been hiking and they're in the mountains, and there is you can have up to 100% saturated. But if they're breathing through their mouth and maybe it's cold, their relative humidity may not reach that 100% like it should. Does that make sense? Okay. So increased temperature, increased capacity. So body humidity is relative humidity at body temperature. Are you seeing a theme here? Know the body temperature and relative humidity. The capacity of water at body temperature, or absolute humidity, at 37 degrees with normal conditions is going to be 44 milligrams per liter. So this is a normal absolute. A humidity deficit is when inspired air is not fully being brought to BPPS. So the body is going to have to correct this. And I'm not going to ask you to calculate a humidity deficit. I just want you to understand that the body has to compensate for the gas that it inspires. So on inspiration, the body is having to make up for the humidity deficit. And if I'm ever going too fast, I try to look at you guys to make sure that you're done writing and taking notes. Tell me to slow down. I don't get offended.
So when your body, you said the body must correct this, what physiologically is going on? What is the body doing or turning on or turning off to fix
So
that deficit?
if there's a deficit, the body may try to increase respiratory rate, even though we have that increased minute ventilation can do the opposite effect and distal, shift that distally. It may increase that, or the body may increase its temperature.
Increase temperature. Okay.
So indications, so always know your indications. So the primary indication for humidity therapy is we're going to humidify dry medical gases. So going back to therapeutics 1, at what liter flow on a nasal cannula would we want to add humidity?
4.
4, yep, 4 or greater. Now, can we add it to patients who are on 2 liters? Yes. So if a patient's complaining that their nares are dry, or you'll have these all the time, patients will take out their nasal cannula and you'll go in because their sats drop and it's hanging down by their mouth. Oh, well, my nose is dry. You can add a bubbler to it and it's not going to hurt them. So patient comfort, or 4 liters or more on a nasal cannula. If we bypass their upper airway, so if we intubate them, we have to add humidity to their mechanical ventilator. You have a whole lecture when you get to IMV on humidity with Justin. Also, if we have a BiPAP, so a patient's on non-invasive ventilation, so BiPAP, CPAP, we will add humidity because we are increasing, hold on, I gotta write something down real quick. We are increasing their minute ventilation, right? So Jade, what can you tell me about the BiPAPs, or Haley too, the BiPAPs that you've worked with at university?
Well, they have heated high flow on them now too, so that's the only time I really see the humidifier actually being used, and they can be used as a vent, but I'm not really sure, honestly.
Yeah,
I know
that's
they're
all
crazy.
I know with the.
And it's like positive and negative pressure, right?
Mhm.
Just positive, but how
Just
fast
positive?
how fast is that flow going? Have you felt it yet?
Mm-mm.
Okay, so it's going really fast. So heated high flow, that's a great one to bring up. You have flows at a minimum of like 30 liters per minute. So we're sending this fast flow to the patient. So it's going to increase their minute ventilation, but it's going to decrease that time that the air has to have contact with the nasal cavity. So it's not going to pick up as much heat and moisture. So that's why we add a humidifier to it. So a humidifier, and we'll add heat to it as well. And we'll talk about different heat settings.
Stacey, I think that, did you say this? Do we add it for CPAP as well as BiPAP, right?
Correct.
Okay.
So we can not just use CPAPs, because most non-invasive ventilators like the V60 have a BiPAP mode, and they also have a CPAP mode, but also home CPAP machines. So we can, as RTs, work with home health companies and go set up people's CPAPs. When you're working in the hospital, especially if you work night shift, you are going to set up home CPAPs for patients. That's usually part of your first rounds, is setting up CPAPs. Some patients prefer a humidifier, some like it without the humidifier. So that's going to really be when they're at home. It's going to be patient preference. But if you had a patient come in and you were setting them up on their CPAP that night, and they usually wear it at home, and they start complaining about dryness, or they say they wake up with a scratchy throat or a stuffy nose, that would be a time that you could suggest, hey, do you use your humidifier? And if they don't know what it is, 9 times out of 10, they don't use it. So show them how to set it up, put the sterile water in it, and then check with them maybe the next night or the next morning and see if it helped them.
So pretty much anything we're adding water to, that's what's being humidified, like equipment wise.
Yes.
Okay.
Okay. Oh, so secondary indications, hypothermia. So if you have a patient who, see, what's a good example?
Pull
So
them out
if
of a
you,
frozen lake, something like
frozen
that.
lake, yep. If you have a patient who comes in and is homeless and they have hypothermia because it's been really cold out, and you put them on a BiPAP, you can add heat to it. Or endotracheal tubes, you're always going to have to add heat to it. So hypothermia can help. So this is going to be heat. So add heat for hypothermia. So know that, heat for hypothermia. And then we have the opposite as well, cool aerosol. So in the lab, we will go over a large volume nebulizer for cool mist. So cool aerosol, also known as cool mist. Because in the medical field, you know, you can't have just one name for everything. Everything has to have multiple terms. So
At
cool
least.
aerosol, at least, yes. Cool aerosol equals cool mist. And we are going to give this to our patients with croup, epiglottitis, and then post-extubations. Not every post-extubation, but if they have stridor. What can you guys tell me about these 3 things? Croup, epiglottitis.
Angry, inflamed airways.
Yeah, they're
Absolutely.
swelling the
Upper
airways.
airways.
That'll kind of, cool air will kind of push them back down a little.
Good, good, good. So we want that vasoconstriction. So everything's inflamed, it's opened up. We know inflammation, all the vasculature is kind of weepy and vasodilated. Cool mist is going to vasoconstrict. So it's going to make all those vessels smaller and reduce that swelling. Okay, so with dry medical gases at 4 liters and greater, the upper airway is not adequately going to be able to heat and moisturize. So we have to add humidification. If it's left unhumidified for a prolonged amount of times, we're going to actually do structural damage. So structural damage happens with high flows that is not humidified. What else needs humidification, can you think of, in the lungs? What do we produce in our lungs?
Mucus.
Mucus, yes, absolutely. So if we're not humidifying our airways, not only do we have structural damage, but our mucus is actually going to start to dry out, which will lead to what?
Plugs.
Bugs, yep. We're not going to be able to move our mucus up and out. So we have bugs that sit in there. And we can dry out the mucus, which can cause mucus plugs.
Oh,
So
bugs and plugs. Yes.
Bugs and plugs,
Yes.
I like that. Okay. Okay, so these are signs and symptoms, so know these, of inadequate air humidification. So atelectasis, because if we have insipated secretions, our alveoli are going to start to collapse on each other. A dry, non-productive cough. So the body's, excuse me, the body is trying to get more moisture, more heat, and it's irritated, and then we start coughing. We'll have increased airway resistance, mostly because of mucus that is not moving. The bugs, we have increased infection, increased work of breathing. Patients can complain, you know, they can have nasal dryness, substernal pain, and then those, excuse me, thick dehydrated secretions. So that's also known as retained secretions or insipate, I can never say it now, insipated secretions. If we put someone on a mechanical ventilator and we bypass completely their upper airway, we can cause damage within minutes to their airway if we don't add humidity. So we're going to go over different types of humidifiers that we can use with endotracheal tubes. And trachs. So trachs need to, even if they're not on the ventilator, our tracheostomy patients will need to have some sort of humidification. Make sure I got all my notes. What breath sounds do you hear for atelectasis? What's the breath sound?
Fine crackles.
Fine crackles, fine inspiratory crackles. And we might see chest x-ray consolidation. And it's usually the left lower lobe. That's kind of the wimpy lobe of the lungs. Okay, so equipment we use. A humidifier, basically, simply put, is a device that adds molecular water to gas. So we're adding moisture to the gas that's being inspired. Just a random question, what could increase humidity output of a humidifier? We talked about an increase of capacity with what?
Temperature.
Temperature.
Temperature, yep. So write these down. So we can increase with temperature, good job. Also with surface area. So if we create a larger reservoir or more water, the gas is going to have more ability to pick up that water. Time of contact. And then thermal mass. So humidification is going to happen by the evaporation of water in the humidifier from the surface. So that's why increasing that surface area is going to allow for more humidification. So we will be able to increase the humidifier's performance by making these modifications. So know what can increase humidity output.
You said surface area, thermal mass.
Time of contact. and temperature. So here again, we have what is going to help increase humidification. So temperature, the higher the temperature of the gas, the more water that it can hold. The surface area, like I said, is going to affect the rate of evaporation. So the bit larger the area, the more evaporation that's going to happen, the more ability the gas will be able to grab that water. So pass over humidifiers, and there's pictures coming up, and we'll go over each of these in the lab so you can get your hands on them and physically see how they work. So pass over humidifiers are typically what is used with CPAPs, BiPAPs, and vents. When you think of humidifiers for your bedroom at home, it's more than likely going to be a pass over humidifier. So what it does is it makes that gas flow pass over a large surface area of water. So if you have like a square box, see if I can draw it. I apologize for my drawing skills ahead of time. So if we have a pass over humidifier here, and this is our water, the gas will come in one area here, and then it goes above the surface area and out to the room, to the patient, to the tubing, however it's connected. So you can see it just basically passes over that water, and it's going
Well done.
to
Good drawing.
that was that was rough, and pick up that moisture as it passes over the top of it. Bubble diffusion, which is in our next slide, directs the stream of gas underwater. So instead of going over the top, change colors. Is going to go into the bubbler, but it'll go under the water. And then as it comes back up out into the patient, it's going to grab the humidity down there. And then wicks use a porous water absorbent material. So think of it as a sponge. Some of them are honeycomb-like, and it is going to pass through. It's a basic, it's like a passive rehumidifier, except it's going to have wicks. And we'll say this is our sponge, and it's going to direct it in. And then the gas is turbulently going to go through this like it would our mucosa and come back out. So it's going to have increased time and increased surface area with a wick.
Would these be on like vents?
Yep. So wick humidifiers can be on vents, and they can be on heated high flows.
Is it just how much humidification a patient needs that indicates the use of a certain type of humidification?
Yes. So with like bubble diffusion, and we're going to go over each of these and when we use them. So bubble diffusion is like our simple bubbler. So that's going to be like
and stuff like that.
Cannula. Yep. And then passover humidifiers and wicks are going to be used on mechanical ventilation or BiPAP.
Cool.
And it's also going to depend on what the hospital buys. So you're not going to necessarily see both wick humidifiers and passover humidifiers. It's usually one or the other.
Yeah, Passover seems like the budget option, and the cool porous honeycombs are a little more expensive.
Yes. And the Passovers are typically what you see in your home CPAP machines as well. Good question. So temperature is the #1 way to increase humidity output. It's going to be the easiest. So if you have a Passover or a wick humidifier, you can't increase that surface area. It's kind of what you're working with. but you can increase the temperature. So time of contact is another thing that we can use to modify. So evaporation increases as contact time increases. So here we have two pictures of bubble humidifiers. So this is a disposable, this is a non-disposable. So this one you can continue to refill with distilled or sterile water. So in the hospital, you use sterile. If a patient's at home, they can buy distilled water at the grocery store and use that. Why would we want to educate our patients not to use tap water?
I don't want them to drown.
What's
Not
in our
clean
tap water?
enough.
Yep, it's not clean enough. So there might be bugs that if they're inhaling can get into their lungs. So if either of these, so if they're only almost empty, they're only that full, we're not going to have much time of contact, right? Because the water isn't, it's missing all this area of contact with water. And it only gets this little area down here. So we can increase the time of contact with these by making sure that they're full. So bubble humidifier contact time depends on the depth of the water column. So the deeper the column, the greater the time of contact as the bubbles rise to the surface. This is important to note. If you increase the flow, you decrease the contact time. So it's the same principle as larger minute ventilation. It's going to go faster through that water. So it's not going to pick up as much humidity.
Would that be the same with the temperature? Evaporates quicker? Not really.
Not really.
Okay.
So if we're talking about Passover or Wicks, it's with the temperature, the evaporation rate's going to maintain the same. And if it evaporates faster and we have a Passover or a Wick, the gas will be able to pick up more because there's more evaporation happening. Does that make sense?
Yeah.
Okay. If we decrease flow through a Passover or Wick, we're going to increase the contact time, right? So there'll be more opportunity for that gas to pick up the moisture. Thermal mass. So the larger amount of water in the humidifier, the greater the thermal mass. So therefore, it'll increase capacity to hold and transfer heat. So we want to make sure that our humidifiers are always properly containing the right amount of water. We want to make sure they're properly humidifying the patient. So the MBRC hospital, or I like to call it the unicorn hospital, this perfect hospital that never has any violations and everything is right. They're fully staffed all the time. So the MBRC hospital, and this will appear on your boards and possibly in an upcoming document that I may give you. Replace your bubblers when half full because it's much less effective. So when you go out to clinicals, you're going to see differences from what I've taught you, or Derek, or Nicole, or Gina. What we've all taught you is going to be different than how some RTs practice. So if we replace bubblers at half full in the hospital, we're putting these on patients who have a lower flow oxygen, right? If they're on 2 or 3 liters and we replace it when it's a quarter full, we're not going to hurt them. So if it goes a little bit below a half full, we're not going to hurt the patient. We don't want to let it run dry, but if we threw away a half full bubbler every time, that would be costing the hospital a lot of money. And it's just not always done.
So this isn't like a take it off, it gets sterilized, reused. You're pretty much tossing these bubblers when they're done.
Yep. And this is the reason the MBRC hospital wants you to throw them away when they're half full, is you have that decreased thermal mass. We've decreased the amount of water in the bubbler. We've decreased the depth of the bubbler column. So we've decreased the time of contact. So I can almost guarantee you that this is a question that you're going to see pretty soon. So types of humidifiers. So humidifiers are either active or passive. So active humidifiers, we're adding heat and or water to the gas. So bubble, passover, nebulizers of bland aerosols, or cool mist, or cool aerosol, or large volume nebulizers, all the same thing. So bland aerosols, and bland aerosols are anything without medication. So when we say a large volume neb for a cool mist, it has no medication in it. It's just sterile water. And then vaporizers. Passive humidifiers recycles the heat and humidity from the patient, or HMEs, and we'll go into each of these. So know which are active and passive. So if all you can remember is HMEs are passive, then any other humidifier is going to be active.
Are those like the filters? Is that what you mean by HME?
HMEs, the heat moisture exchangers, they look like filters that are used on BiPAPs and
Like
vents.
transport vents?
Yeah.
Okay.
So bubble humidifiers. These break into bubbles as the gas, okay, let me start over. As the gas travels through the water, it's going to break the water into bubbles. And these small bubbles, the gas is going to pull the heat and moisture from the bubbler. These do not always have heat. So they're typically unheated. You can get a yoke that sits on top of the bubblers, but when we add heat to a plastic thing like this, what are we afraid of?
Any
Melting.
kind of fume or melting.
Yep. So if we get busy with patients, or the nursing can add bubblers to nasal cannulas as well, and we put heat on it, and then we get busy and we're not checking the bubbler, or they're not being seen by respiratory and nursing's not paying attention, or CNAs are not looking, and it becomes empty. So it's going to dry out the bubbler faster with the heat. And it's also, we risk that melting. These include a simple pressure relief pop-off valve. And it's a warning of obstruction. So if the oxygen tubing gets kinked, and it sounds kind of like a tea kettle going off, is what the pop-off valve is for. And it prevents it from bursting. So it's going to make this loud, high-pitched noise to get somebody's attention to say, hey, there's some sort of obstruction, back pressure going off, the gas cannot get out of the bubbler, and we don't want it to explode. So the alarm will go off when there's greater than or equal to 2 PSI in the bubbler. So sometimes if you hear that screeching tea kettle sound, check the oxygen tubing Sometimes if you have a patient who gets up in the morning from bed and they're sitting them in the chair, sometimes the chair gets rolled over onto the oxygen tubing. That can happen. It could be a kink in the bed rail. So you're going to want to check for a kink first. So this can produce, if we use a high flow beyond what the bubbler is capable of, which is greater than 6 liters per minute, it can produce aerosols. So if we're producing aerosols through a bubbler, which we don't want, we can have condensation build up in the tubing. And that can lead to higher infection rates, because where does bacteria like to grow?
Warm, water, wet.
Yep. Warm, moist places. So we have increased infection risk, and we can also increase obstructions. So the patient's not getting the proper gas flow. Make sure I have all my notes. So if you hear the pop-off valve, what should you do?
Check for kinks.
Yep, check for kinks or any obstruction. What type of patient would this work best for?
Floor patient with nasal cannula.
Yep, floor patient with a nasal cannula. What flows
Something less than 6 liters per minute.
less than 6 and more than or equal to? When do we have to add? 4. Yep, 4. So this should be put on somebody who's at 4 to 6 liters, but we can put it on someone less than 4 liters if it's indicated.
Stacy,
they-
do they use bubble humidifiers in the NICU too? Or is
They
that,
use bubble CPAP is what you're thinking of.
okay, okay.
So that aerosol production, it's never done on purpose, right? With these.
Correct.
Okay.
Correct. So that would be, there are, so if you, let's see, where is it? So this one here, you can use these for higher flows. You'll see nasal cannulas that go up to 15 liters, and they're just a larger bore oxygen tubing. You can use these, and they're indicated for higher flows. But for these little ones, less than 6,
Gotcha.
because they won't create aerosols. And these are created so that they won't create aerosols at the higher flows.
At those higher flows.
Yep.
So cool.
So no bubbler should create an aerosol. Good question. So this is what the bubbler is doing. So in the top, you have that pressure release valve, and the gas is being fed in via a capillary system into the reservoir. And as it bubbles back up, when it shatters the water into little bubbles, that's where it's picking up the moisture and then being delivered to the patient. So this would be an example of a heated bubbler, which is not common. They do make them, but I have not seen them out in the hospitals. You can have a heater on the bottom, or there's some wraparounds that sit on the top. If you add heat to a bubbler, we're also worried about condensation, because the water or the air is warmed here, but as it leaves the humidifier and the heat and it travels to the patient, it's getting cooler. And so think of it like you're drinking ice water. And as you set the ice water down and the warmer room temperature air around it pulls the condensation out of the glass. So condensation can happen if we heat the bubbler in the oxygen tubing, which poses a risk for infection and obstruction. Okay, so our passover humidifiers. So like my little picture, you have, this will be connected to either a non-invasive ventilator or to a mechanical ventilator. And you have circuits. So one hose will hook up to the machine, and this other side will hook up to a circuit that goes to the patient. So it'll come from the machine, go into the humidifier, and through evaporation, pass over the top of the water surface, pick up the moisture that has been heated from this plate here. This is the heater down here, and then go out to the patient. So the gas is being directed over the top of the water surface. We have a simple reservoir, a wick, and a membrane. So this picture is of a simple passover reservoir. The advantage for this humidifier is it maintains saturation at high flow rates. So these are great for our non-invasive ventilation, BiPAP, CPAP, heated high flows, mechanical ventilators. So know which type of humidifier would work best for either specific patients or what type of oxygen they are receiving, whether it's a nasal cannula or if it's a trach patient who's on mechanical ventilation. There is little or no flow resistance, so we are not going to directly affect what we want delivered to the patient. And these do not generate any aerosol because the gas isn't going into the water, so it's not a risk of generating an aerosol, it's just passing over the top. Okay, so here again, active humidifiers, the bubbler, which goes into the water, the aerosol, which is like that large volume neb, goes into the water, and then it generates aerosol particles above the reservoir. And those are coming up too. And then the passover. So the membrane, this membrane here, excuse me, is a hydrophobic membrane, and it separates the gas in the water reservoir. So the water is below the membrane, so the gas never actually touches the water. But the water vapor passes through the membrane so that there's no liquid particles. So if you see a vapotherm, it's going to be a membrane heater and humidifier. And then this is really common more in kiddos. So in the NICU, they like to use the vapotherm for their CPAP. Okay, we'll do a couple more slides and then we'll take a break. So heat moisture exchangers, or HMEs, capture exhaled heat and moisture. So it's recycling what the patient is exhaling. So it's going to hold on to that heat and moisture just like their nasal cavity would. It's indicated for short-term mechanically ventilated patients. Short-term is the key word there. Short-term. So if you have someone, if you see on a test, your patient is going to be intubated and they've had a heart surgery and they expect to be extubated within the next 2 hours, HME would be a good choice for them. If they are intubated and they have sepsis and they're very sick and there's no indication of when they're going to get off of the mechanical ventilator, you would want to change them to a passover or wick humidifier. So HME is for short-term patients. Transports. So at St. Anthony's, we had these little transport vents. They didn't have humidifiers on them, so we would put an HME in line with the circuit and take them down to CT or nuclear med or whatever they needed to do. And then once they got back to their room, we'd pop them back on their mechanical ventilator that was already hooked up to their passover. You'll also see this post-op for patients. So if they're in recovery and the anesthesiologist just had a hard time getting them extubated, the meds weren't wearing off as quick as they thought, they can leave them, you can leave them on HMEs because you assume that they're going to be able to be extubated. Now, if they've been intubated and then the surgeon comes up and says, hey, let's just leave them intubated for the night, you might want to switch them to a passover humidifier. So anything less than or equal to 96 hours. Know that number. So contraindications would be excessive secretions, because where the HME is at, it's going to be between the circuit and the endotracheal tube. So if they have excessive secretions, sometimes these secretions will come up the endotracheal tube themselves, and then they saturate that HME. And the HME is going to lose its integrity, and it's not going to do its job. Plus, it can cause increased airway resistance, higher infection rates. It's just nasty. So if you walk into a room and you see someone's on mechanical ventilation and they're going to be extubated in a few hours because they just had surgery, but there's a ton of secretions in the HME, what would you do?
Change them over.
Yep.
To a different humidifier.
Yep, you'd want to just change them to passover humidification. Because if you just change the HME, it's going to keep happening again and again. And we want to make sure that we are keeping our patients. You're going to have to keep breaking the circuit, which means you're taking them, you're opening that closed circuit from the vent to the patient, which increases their risk for a ventilator-acquired pneumonia. So the more you break it, the more you increase that risk. So you just want to throw away the old HME and switch them over. If they have thick secretions, it's the same principle. So excessive or thick secretions, because we want to really make sure that we're humidifying those thick secretions so that we can get them up and out. If they have really large tidal volumes or a fast minute ventilation on the vent, you're going to want to change them because it's the same thing as if they were off the ventilator and they had a high minute ventilation. It's a decrease in that time of contact, because these are also known as the artificial nose, because it does the same thing as the nose. And then hypothermia. So if our patient came in and they're hypothermic, we wouldn't want to add an HME. We want to control their heat so that it's body temperature. Because if their body temperature is less than 37 degrees Celsius, recycling that air is not going to increase its temperature. You need to note that this adds 30 to 90 mLs of dead space. So when we measure this dead space, we measure the circuit to the ventilator. Circuit to ventilator, and then to the patient's airway. So this is going to add 30 to 90 mLs of dead space, which is going to increase our CO2. Is there a patient population that dead space could be an issue?
Spears COPD or air trappers?
It could with them, but 30 to 90 mLs with them isn't going to be too bad because we can compensate for it on the vent. So infants, they're so little,
Tiny lungs.
they're
Yeah.
tiny, but 30 to 90 mLs of dead space is just, it's going to be terrible for them. So do not use HMEs for infants. So if someone suggests, you know, in an upcoming document that the physician wants to use an HME on an infant, you would just change them to another humidifier. So you would use a passover or a membrane humidifier. So contraindications, infants.
There's a lot of contraindications on those HMEs.
Yes, yes, there is. And infants, that's like their tidal volume, is 30 to 90 mLs. And they use uncuffed endotracheal tubes because that's how they get rid of their CO2. Make sure I got everything. Yep. So there are different types of HMEs. There's the simple condenser, and it contains a condenser element with high thermal conductivity. So it's going to recycle that heat. You have hygroscopic and hydroscopic. And the biggest thing that I want you to know is that after continued use, if you use these longer than indicated, or if we have excessive secretions, that we will increase our flow resistance to the patient. Because that filter in the middle of these HMEs are going to become saturated with water and moisture, that it's going to be harder for that gas to flow through the HMEs. Okay, let's take a break and come back at 2:05. Sound good? All right, I'll see y'all then.
And I still am so lost after spending a couple hours yesterday looking at them.
That's okay. It's understandable.
I much prefer the Bruck stuff we went over. That's cool.
Nice. Broncs are fun.
Yeah. So we'll go in for lab day tomorrow.
For chest x-rays?
Or no, wrong. We're not doing lab day. We're studying for our final.
Ah, and then you start
Tomorrow.
diseases.
And then we start disease next week.
It's a fun class.
Sorry, Elizabeth. I saw your face. I was like, nope, that's not a lab day. Hang on a minute.
Okay, let's continue with humidity. Okay, so these heated humidifiers, sorry, typo on this slide. So passovers and with heat are always going to be placed on patients on mechanical ventilation. Always, always. Because if we put them on mechanical ventilation, we can do damage to the airway within minutes. So when you're out on clinicals, even on your first rotation, you'll probably be asked to go to the ED. I always recommend, so if you're somewhere and you hear a trauma being called or RTs being called to assess a patient for intubation, and they ask, or you can ask, you can say, hey, can I go with you? I always recommend going and seeing everything that you can. So in the ED, at times, you may not see humidification being used on the patient, but HME should at least be used. And then for long-term ventilation, we are always going to use passover humidifiers. Now, what I say and what you see may be different. one of my students called me on their IC rotation and was like, this hospital only uses HMEs on all their mechanically ventilated patients. It doesn't matter how long they're on the ventilator. And it floored me and Nicole, because Nicole taught this class before me. And I was like, did something change? Am I missing something? And so she went and looked at respiratory care articles, and I went to AARC because the AARC has clinical practice guidelines, which is what respiratory departments use to make their hospital protocols and policies. And it's still up to date, recommends that HMEs are not used over the 96 hours. So what you hear from your instructors and what you see out there may be different. And I personally, if I'm on an event, would not want an HME used for long periods of time because it can cause that damage. So that being said, for class purposes and out there in other hospitals, you're always going to want to add heat and a passive humidifier to your mechanically ventilated patients. So risk can be airway burns, and the biggest, not the biggest time, but this is more likely to happen if the passover, let's see if I can't see with my little squares. So you can see here, this little reservoir. If the reservoir goes dry, you're more likely to overheat the gas that's running through the humidifier and going to the patient. So that can cause airway burns. So part of your ventilator assessment needs to be checking the humidifier, making sure that either the reservoir is full, so if you have to fill it up with a bottle, or if it's using a gravity fed system, which we will talk about, making sure that that bag of inhalation water is full, or that it's going to last until you come back for your next ventilator assessment. So it's uncommon for airway burns, but that's when it will happen. We have an increased risk of infection when we add heat if there's condensation in the patient circuit, because bacteria likes to grow in moist, warm spaces. So you can see on this picture, once it's turned on, it'll read the temperature here. And you can turn it up or down. So if we are completely bypassing the upper airway, we want to set it to 37 degrees Celsius or body temperature. These are also used on BiPAPs and non-invasive ventilation. So heated high flow or BiPAP, or on CPAP, you would want to set it to 32 degrees Celsius, because the upper airway still can heat and add moisture to some of the air, but it needs help. And then
You said set to 30 what? I'm sorry.
32. And
Celsius?
Then, yep, Celsius. I have like a frog stuck in my throat today. I apologize. It must be allergy season. And then most of these heaters auto set alarms, so you won't have to set them at +2 degrees Celsius and below 2 degrees Celsius. So once that temperature hits, if you have it set at 37, once it hits 39 degrees Celsius, it'll make a terrible, terrible alarm that your nurses will go crazy and call you over and over again until you fix it, because it's obnoxious.
I
Or
love that sound.
do, 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 that one.
Yep. Mm-hmm.
You'll start to hear alarms in your sleep once you're out in the RT world. When I first started at St. Anthony's, their code blue chime that went off before they said the room number and stuff is the same one that they use for their intercom at Hobby Lobby. So I was at Hobby Lobby with Roland and Marilyn, and all of a sudden that chime went off and I just stopped and listened. And my husband was like, "What are you doing?" I was like, "Oh, sorry, habit." I will never live that one down. Okay, so auto set alarms. Okay, so heat sources can be a hot plate. So this is the Fisher-Paykel. This is the most common one that I've seen at hospitals in our area. And that silver thing here is a hot plate. a little tip. Be careful when you're changing that reservoir on top. Or if you're Jade and Haley, have you burned yourself yet on one of those when dressing a vent? They get super hot. So if you have to change the heater, change heater wires, the reservoir, if you have to mess with it, be careful and pay attention to what you're doing because that gets hot and you can burn yourself.
The Airvos have these filtered circuits that we have to put on for cleaning them, and those get super hot. I've burned myself on that one, but never on I haven't done it on this one yet.
It might happen. With the Fisher-Paykel, what's nice is this button here. It's hard to see in this picture, so in the lab, I can show you guys. You can switch from invasive, so endotracheal or tracheostomy, mechanical ventilation, or non-invasive here. And it automatically sets it to the temperature correct for the patient. You have a wraparound. So it looks like a little donut and it just sits on top of the bubbler. And then you can adjust the heat setting. You have a yoke or a collar, which is like this guy. So this is a Venturi device. So we'll go over this with large volume nebs. And it sits on top of the sterile bottle of water so we can add heat to it. So this is going to be for an aerosol, large volume nebulizer, bland aerosol device. You have an immersion heater, which goes into the reservoir itself and sits in the water. And then you have heated wire circuits. So these heated wires are actually in the patient circuit. And there's a picture on the next slide we'll go over. So heat sources are either simple systems or servo controlled. So our simple systems, which is like a base heater, is very basic. And the controller, or us RTs, are going to monitor the heating element. So this would be a simple system because we're going to make sure that there's adequate water, that it's functioning properly, and that basic settings are set. And then servo controlled are going to be like your Fisher-Paykel. And the unit itself is going to monitor the temperature. It has alarm capabilities. And it does this by using a thermometer probe. So let's see, let's go to this page. We'll get to it. So on the patient circuit, there's heater wires that plug in on the side of the humidifier. And then at the end of the circuit, there's a little hole where you plug in the temperature probe. And so it's monitoring the temperature when it leaves the humidifier, and then the temperature once that gas reaches the patient. So if it gets too hot or too cold at the patient end, the alarm will go off. With servo-controlled units, if the machine or the patient temperature gets too hot, the heater will shut itself down. So this is going to help you with patient safety issues. So we have reservoir and feed systems. So you're familiar with the reservoirs. So feed systems is going to use gravity to continually refill the heater or the humidifier. So this is the best picture I could find, but you could see, so here is where the tubing goes from, where is it? Here it is. From the reservoir to the heater. So as gravity is going to pull from the bag, or in this case, the container, and put it into the reservoir in the humidifier itself. So if we go back to this one, and we have our humidifier sits on top here, the bag, we'll say the bag is up here, and then via a capillary tube, it comes down and it drips into the reservoir. This is actually a better picture. So the bag and the capillary tubing comes down, and it hooks in here, and then it just slowly drips and refills that reservoir. So you just need to constantly make sure that the bag is full enough until either you can change it on your next ventilator assessment, or I like to bring in an extra bag. I always bring in supplies with me so I'm not in a pinch, because this is something that nurses can spike the bag and change it too. If they see it's getting low or the heater is alarming because it needs more water, they can replace it for you too. There are still some manual systems. Those are going to be more common at smaller hospitals. And that would be taking a bottle of sterile water and then manually refilling it every time you do a ventilator assessment. But that can alter the temperature, because if we're adding a large amount of sterile water to the reservoir system, it's going to take longer to warm that water up rather than a gravity fed system that is adding just a little bit at a time as it evaporates. We're technically breaking the seal, so we have increased infection risk, and it interrupts mechanical ventilation, because as you're taking the patient circuit off to refill that reservoir, they are losing that flow. So if we have someone who's on a large amount of PEEP, so positive end expiratory pressure, they're on large amounts, we're de-recruiting them because we're interrupting that gas flow. So that's why manual systems aren't as common anymore. So the right settings. So when your hospital purchases humidifiers, they're going to make sure that they purchase humidifiers that are going to meet the needs of mechanical ventilation or non-invasive ventilation. Bubble humidifiers are all going to be the same, but they need to provide optimal levels of humidity. So you're not going to need to worry about having the right humidifier. You're going to need to worry about choosing the right humidifier for your patient. So choosing, should this patient be on cool aerosol because they have a trach and they just need humidity? Should they be on a bubbler because they're on 5 liters nasal cannula? Are they complaining of airway dryness with their CPAP? Well, let's fill up their Passover humidifier and try that. So being able to pick the patient with the right humidifier. And then if you are adding heat, putting them on the right temperature. So making sure that anybody who has a bypassed upper airway, whether a trach or an endotracheal tube, that you set 37 degrees Celsius, or if they're on non-invasive BiPAP, CPAP, or heated high flow, that they're on 32 degrees Celsius, and that gas temperatures never reach greater than 40 degrees Celsius. If they do, an alarm should be sounding on your heater, because when we're setting these temperatures, we're using those servo-controlled humidifiers. Okay, so problem solving and troubleshooting is a huge part of our job. So condensation is something that we are always worried about as RTs. Why are we worried about condensation with our mechanically ventilated patients?
Aspiration, just making it worse. Pneumonias,
Yep,
infection.
aspirations. Infections, when our patients are mechanically ventilated, we are worried about VAP, ventilator-acquired pneumonia. If a patient gets an infection in the hospital, their insurance doesn't pay anymore. Then it's out of the hospital's pocket. If our patient gets an infection caused by us due to a VAP, that's going to come out of respiratory's budget. We're going to get dinged for it. And our budget, respiratory department's budget, that's where raises come from. That's where new equipment comes from. So it's imperative that not only just for the safety and well-being of our patients, but for what you want as a department and how you want to grow, that you're taking care of these precautions.
It's got to be tough with all this COVID and that, and how do you differentiate between a VAP and just a system-wide problem? Right.
So and I don't know how it's changed with COVID. That's a good question that I'm gonna have to ask some of my friends. But St. Anthony's would have things in place, and we wouldn't have just VAPs, we'd have ventilator acquired events, so VAEs. So if a patient went up on their FiO2 more than 10% or an increase in PEEP, and it couldn't be titrated back down within 12 hours, we'd be dinged. So they were always making sure that we were actively trying to decrease PEEP and FiO2 on our vented patients, because that's what we should be doing as RTs. Sometimes RTs get in a routine and they're not always actively trying to change FiO2 and PEEP. So there's little things that get flagged like that through charting. Condensation wastewater, and it occludes gas flow through the circuit. So we're going to increase their airway resistance. They may become air hungry because they're not getting the adequate flow they need. We covered aspiration. It can alter FiO2, the ventilator's function, so the vent's having to work harder to get the correct either pressure or flow or volume delivered to the patient. So what we can do is we can either use water traps in the circuit or use heated circuits. Now, in the Denver metro area, we have larger, bigger hospitals and hospital systems that have more money. So they're more likely to use heated circuits. Somewhere that doesn't do a lot of critical care may use water traps because heated circuits are more expensive. So with heated humidifiers, what happens as gas travels through the circuit into the patient? Assuming there's no heater wires in it, it's just a regular circuit.
It cools.
Good job. Absolutely, it cools. So then we have that condensation. So then we're worried about aspiration and all of these other problems. So that's where the heated circuits help. They prevent that condensation. So this is just a picture of how it works. So you have the heated humidifier, the gas source. So this is going to the mechanical ventilator, and then it's going to pass over the top of the water and go to the patient. Now, if this is not heated, you risk condensation in this tubing here. So look at how this circuit is, you assume the patient's here, the direction of this circuit, and this is not a heated circuit. What's going to happen to this condensation in this tubing?
It's going to end up inside the patient.
Yep, it's going down, so it's going to end up inside the patient. So something that you should always be aware of are your hospital's policies and protocols. So, and then creating your own routine. So when you walk into a room, you're going to develop your own routine and what works best for you. So walking into a ventilated patient's room, I'd always put eyes first on the patient. So you always want to look at the patient first and kind of get a lay during my first vent assessment of how their room is laid out. I check the circuit, make sure that it wasn't, because sometimes circuits will get moved to turn the patient, or the patient's getting in and out of bed. You're doing early mobility. Just make sure that it's not angled like this, because then anything that's in the circuit is going to go back down into the patient. If you're going to give a neb treatment and I left it like this, what would happen? So the neb cup would be
the
then,
medication.
yep, condensation would go into the medication, because you're going to put the neb cup here, and then condensation is going to drip into the neb cup.
So you're just diluting your neb treatment
Yep,
unnecessarily.
unnecessarily. And then it's going to take longer to do the neb treatment because it's continually filled with fluid. And we talked about why heated circuits aren't used at every hospital. Here we have some heated circuits. So this is a good setup. So this is a good setup for a neb treatment. It sits in the cup, and then you can see the blue. Generally, blue is always inspiration, and white is the expiration. So inspiration is coming from the vent, and it's going straight across this way. So you can see the inspiration tubing is straight down, and then the neb is in between. And this is a good picture, because this is where the temperature probe will go at the end of the circuit and then on the patient's airway. So it's measuring here and here. So infection is another risk. We're worried about bacteria, so we want to minimize condensation. Wick and membrane passover humidifiers help prevent the formation of aerosols. So we don't want any aerosol. We want to decrease the amount of times we change the circuit and break the circuit. So that means we don't want to change it unless we absolutely have to. If it's physically soiled and you can see that there's a lot of just gunk, blood, mucus, anything in the circuit, you want to change it. You just want to decrease how often you change it. Some hospitals have policies where they change it once a week, some change it every other day, some change it as needed. So it's just going to depend on what hospital you work at. Now, these are circuits that are not heated, but they have those traps in the middle. Where should those traps be to get that, catch that condensation?
The lowest point of your
lowest point.
circuit.
Yep, so we want to make sure if we're moving the patient around and the trap gets put on the bed or in the bed rail, we want to make sure that we put it down at the lowest point. So therapies that we can do with humidity and bland aerosol. So bland aerosol, remember, is nothing with medication. So we're not using albuterol or mucomist or any of those drugs. So it's liquid particles suspended in a gas. And that gas can be oxygen or air. So we can use sterile water or sterile saline. What's hypotonic mean when we talk about saline? Isotonic equals?
It's neutral.
Yep. So that would be 0.9% or body salinity.
So hypo would be
Hypo
low
would be,
salinity.
yep, less than 0.9%. So hypertonic would be greater than 0.9%. And the most common percentages for hypertonic are 3, 7, and 10. When would we use hypertonic saline? I don't know if you went over this in an intro to pharm or not. No? Okay.
Wasn't
So-
there
I mean, I'm just-
one situation where you're trying to irritate someone's airway?
Yep. When you're trying to irritate someone's airway and get a sputum sample.
That cough induction.
Cough induction, it's used for CF patients on a daily basis because their mucus is so thick and nasty and their sodium chloride channels don't work properly that they hypertonic actually moisturizes their mucus so they can cough it up and out. It adds the salt their mucus needs. So anytime you see tonic, think salt. So the difference between humidity and aerosol. So humidity is water vapor in the gas phase, and aerosol is liquid particles suspended in gas. Humidity is water vapor in the gas phase, and aerosol is liquid particles suspended in gas.
So you're a hypotonic then? If isotonic is your normal, neutral, hypertonic for cough induction to purposely irritate, would hypotonic be if the airway is already irritated and you don't want to induce that cough in your patient?
Yeah, so hypotonic, if you use a saline, it can be used for cool mist.
Okay.
Stacy, can you do the one more time? The humidity was what and aerosol was what?
So humidity is water vapor in the gas phase, and aerosol is liquid particles suspended in a gas. So anytime you see bland aerosol, think bigger particles. So bland aerosol indications, upper airway edema, we want cool bland aerosol or cool mist to help decrease that inflammation. So this would be a picture of what it would look like with post-extubation edema or glottic edema. What would their breath sound like? What would you hear probably as you walked into the room?
Strider.
Like the, yeah.
Yep, stridor. So we would put cool mist on them. What medication could we use to nebulize?
Epinephrine.
Yep, epinephrine. We get some racemic epi really quick. Croup could be cool mist. So if you have a kiddo come in and he has a barky cough, and he may have stridor, he may not, you'd want to get some cool mist set up. Subglottic edema, post-extubation edema, post-op management of the upper airway. So if maybe they had to be nasally intubated for surgery, where they have some airway soreness. Sometimes you'll have patients who have facial surgery or severe bloody noses, and they need that humidity to help prevent more bleeding. Tracheostomy. So some patients it's going to be patient preference for long-term trachs who live with them and they're not acute because of a surgery or they're new in the hospital. Long-term trach patients, some will prefer cool mist and some will prefer heated. So if they're not mechanically ventilated with a trach, we will use bland aerosol. And then sputum induction with iso or hypertonic saline. When would you want to recommend a sputum induction? what might the patient look like? Don't overthink it. What are some signs and symptoms?
Increased work of breathing.
Mhm. Maybe they have a fever. They said they,
Infection.
yep, any signs of infection, respiratory infection, a cough. They said that when they looked at their mucus at home, it was bright green. So those would all be signs and symptoms that they may need a sputum induction to see if they're growing anything. So remember the difference between sputum and mucus. Sputum passes through the mouth. Sputum is mucus that passes through the mouth. So large volume jet nebulizers are used for bland aerosol or cool mist. They are pneumatically powered. So you can see in the picture here, they attach straight to the flow meter. And then we'll look at these in person. You adjust this orange dial here to the FiO2 that you want, and you will change the flow based on your desired FiO2. So you don't need to know exact numbers. Know that if you add heat to these nebulizers, they will produce higher rates of humidity.
Is this mainly for trachs?
You can use, yes and no. So yes, when you're using them in the hospital, typically you're putting it on a trach patient, but these are what we're gonna put on our patients with croup, post-extubation stridor, anytime they need cool mist, this is what we're gonna use. We just happen to use it more often because we have more trach patients. So large volume nebs and how they work. So this is going to attach the flow meter here. And then you have your jet orifice, which is going to kind of start splitting the air. The gas will go through the water and then back up the capillary tube and out to the patient. So the water is going to be shattered into liquid particles. So these particles are bigger than the other humidifiers. So remember, aerosol is larger particles. Are they monodisperse or heterodisperse? Are all the particles going to be the same size or different sizes?
Different sizes.
Different
Hetero.
sizes. So there's all different kinds of large volume nebs. So this is called a mistiox. And you can look at each individual neb and piece of equipment that we talk about in White's equipment book, and it'll go into more detail about each. So the mistiox is a little bit bigger on the top than the other large volume nebs because it can be attached to a high flow meter. So this is going to provide specific FiO2s at a higher flow. These are the ones that you will usually see in the hospital, very similar. They're disposable, so you're not going to refill the container. You're going to throw this container away and get a new bottle of sterile water. Something with trach patients that I recommend is your first rounds are always going to take the longest at the hospitals. You're going to have your own routine, your own flow pattern, what works best for you, what you like to do, how you want to set yourself up. So first rounds, what I would do is I would go in, I have a trach patient, I would check all of their supplies and make sure I had everything I need, and then restock if I needed to. And then last rounds, I would always make sure that everything was replenished for the next RT on day shift. Don't be that guy that empties out all the supplies and someone follows you and is like, really? I have to go get everything that I need again. Just keep replenishing. If you use the last, put a couple back. And don't do it to yourself either, because you're going to need to do something or grab something and you forgot to bring it in last round. So take the time. Don't leave yourself or others in a bind. If the water is low in your container and you're not sure if they're going to be dry, if it's going to be dried up before you come back for your next round, just refill it. And don't, on your last round, you see that, you know, maybe it's down to here. Just refill it for the next guy, because you don't know if maybe you switch shifts and all of a sudden they get called to a code right away, or they have to go see another patient, or they're not going to go see him first. And then this trach patient is without humidification because they didn't know that he was almost gone. Okay, lost my soapbox. And then this is a home large volume neb, and it's attached to a collar heater. And you can tell you can't set the temperature exactly. You can just do more heat, less heat, and on off. So that's something that they need to monitor to make sure that they don't have any adverse effects. Okay, so attached to our large volume nebs, we're going to have this blue corrugated tubing, and I'll show you how to set it up when we go to the lab. So one end will attach to the large volume neb, and then you'll have a drain bag in between, and then another piece of blue corrugated tubing that will go to either an aerosol mask, which can be used for nebs as well, so medication nebs. If the patient can't handle a mouthpiece, a face tent, a T-piece or a Briggs adapter, a tracheostomy mask, which is also called a trach collar, and all of these are used with the large bore corrugated tubing. So here's pictures. It's easier to see than to describe. So here we have an aerosol mask. This is not a simple mask. Don't call it a simple mask, because then you will confuse your nurses. So this is an aerosol mask. What are the holes for?
CO2 expiration.
Get rid of CO2, wash it out. It attaches to the corrugated tubing here, or the small volume neb. You have your trach mask, your trach collar, your Briggs T-piece adapter. So this end here attaches directly onto the patient's trach. And then this side will attach to corrugated tubing. And then you have, this side will be where you wash out CO2 for expiration. And then your face tent here. So this may be for someone who feels claustrophobic. So someone who can't handle that aerosol mask sitting on their face like this may prefer the face tent because it sits under the chin, below the face. Or if they have had facial surgery, you'll see these, excuse me, a lot with patients who have had some kind of accident or trauma, and they've had to have facial reconstruction surgery, but they need humidity. A face tent isn't going to add direct pressure onto their injuries. What may be a concern with a T-piece rather than a trach collar?
Worry about condensation building up.
Condensation. What about if they move a lot?
Displace it or knock it off.
Yep, you could knock off the T-piece, or we risk pulling out the trach itself. So this is going to be, again, if we have a long-term trach patient, or if you can talk to your patient who has the trach and say, hey, you know, try not to move around as much or be very careful when you move so you don't pull on the tubing. But then if you have a neuro patient who's not really cognizant and with it, you may just want to switch to a trach collar.
How, and this is, I don't know, but how easy is it to displace a trach?
It's
I
pretty
mean, is it
easy.
just like it's just rolling over in the night or something like that, and it
That's why I'm going to teach you how to properly secure your trach.
okay.
It can be easy, but it shouldn't be that easy. If it's properly secure, if they roll over on it, if it's a fresh trach, first of all, it's going to hurt because their stoma hasn't healed, but it shouldn't pop out that easy. Good question. Enclosures. So this is going to be for your pediatric population. You have mist tents and hoods. And these are going to deliver aerosol therapy, like I said, to infants and children. They can retain heat, and CO2 can build up in the tents. So it's something that you need to make sure that you're setting up properly. If you were using these, you need to make sure that you're reading the manufacturer information because it's going to tell you how to properly set up these items. That being said, with any of the equipment that I'm teaching you about, if you're unsure of something at your hospital, because every piece of equipment is going to be a little different and vary from hospital to hospital, in the packaging, when you open it, there will be instructions. Don't be afraid. Even if you're a seasoned RT, I've had to do it before when we get new equipment, sit down and open it and look at it before you go to the patient's room. Don't be embarrassed and think that you should know it. It's absolutely okay. Okay, sputum induction is cost effective. Again, we use it for diagnosing infections. So think about scenarios, because this is the part of the program where we start giving you clues on what the answer should be. So we might give you a scenario. The patient is running a fever. They're complaining about cough and shortness of breath. Maybe they have retractions. They have coarse crackles throughout, which is an indication of mucus in the lungs. So start thinking of signs and symptoms, and we'll start helping you piece things together. So you might say, okay, the physician, I'm going to recommend a sputum induction to the physician because I want to get a culture and sensitivity. It's also used for mucociliary clearance, which thins secretions. We talked about this is more common with our CF patients. And it encourages cough because it irritates the airway. So what is something, if we're using hypertonic saline for mucociliary clearance, what drug should we pre-treat with? It's going to irritate the airways. Or bread and butter.
Albuterol?
Yep. albuterol.
Hypertonic. Oh.
We'll pre-treat the hypertonic with albuterol. That way we help prevent that irritation and the bronchospasm. So remember, hypertonic most commonly comes in 3, 7, and 10%. So some things we worry about with bland aerosol therapy, again, infection. Infection is going to be our biggest not contraindication, but risk with both bland aerosol therapy and humidity. Environmental exposure, so that would be us as RT and other healthcare providers. The aerosols are still floating around in the air, so make sure that you are protecting yourself. You don't want to breathe in other people's bland aerosol, especially on exhalation. Inadequate mist production, so that's our equipment not functioning properly, whether we need to refill the bottle or there's an occlusion somewhere or built up condensation. So make sure you're checking their tubing for condensation and draining it into the drain bag. And then once that drain bag gets full, emptying it into the sink or the trash can. Overhydration, so if we're giving too much humidity to our patient, we can shift that ISB up. So overhydration can shift the ISB up.
And that's an issue, just increasing the chance for infection or bugs to land higher up in the airway.
Yes. If we're overhydrating them, then that may be a sign that we can try them without bland aerosol. That it did its job and now we can try it without. Bronchospasm, if it irritates their airway, and then noise. So large volume nebs that's constantly running, you're on a minimum flow of 8 liters per minute. If patients are trying to sleep, they may complain that it's too loud. If there's condensation in the tubing, it makes a funny noise, and the air entrainment device. So make sure you're checking your liter flow, because sometimes, and we'll go over this again in lab, sometimes on higher FiO2s, you have to have a 10 liters per minute flow. But sometimes nurses will turn it down to 8 because the patient's complaining it's noisy. So that's just an opportunity to educate your nurse and say, hey, you know, I noticed this, but this is why it needs to be a 10. I'm sorry it's so loud. Maybe we could try going down on their FiO2 and see if they tolerate it. So you're being nice and you're killing 2 birds with 1 stone. You're titrating their FiO2 if they can tolerate it, and you're decreasing the flow. Make sure I got all my notes. Okay. So here we have a little scenario. After abdominal surgery, a 50-year-old man is brought to the recovery room and started on an aerosol mask at an FiO2 of 50%. While performing your initial assessment of this patient, you notice his respiratory rate is 20 breaths per minute, and he shows no sign, and he shows signs of respiratory distress. You also note that on inspiration, the aerosol stops flowing from the mask. How would you remedy the situation to ensure the patient is receiving 50%? This goes back to therapeutics 1 as well.
Increase our flow.
Yep, increase flow. Make sure there's no obstructions. So make sure there's no condensation. Maybe his tubing got kinked in between the chair and the wall. So making sure there's no obstruction.
Check bubbler and LVN if they're attached, if they're empty or halfway. Yep,
exactly. So it's basically, it's not meeting his demands. So you want to first see if it's a trouble with an obstruction, and increase. If it's not, then you increase the flow to make sure you're meeting his demands. If you cannot increase it anymore, if you go up on the FiO2 and the flow, then you'd want to switch to maybe a Mistiox, which is the high flow. Good job. Okay, you guys did a great job. Any questions about that? We'll go over the homework real quick, if you would like.
Sure, and I think
wanted to make sure, so since there's, go ahead.
No, you.
Are you sure? My internet was all weird. It was all quiet for a sec. I just wanted to make sure that since there's 2 days for each lab, on the days that there is the lab we're not doing, we just have like recorded stuff?
On the, good question. So on the days that you're not in lab, the campus is getting new flooring and it totally messed up our therapeutics schedule. But so we'll have all the theory and lectures at the front half of the course, and then our labs later, which will actually benefit you before taking your final, because we'll refresh on everything while we're in lab. But after we're done with the lectures, that have labs with them, we won't have any recordings. So you'll be doing different assignments. I'm going to put together some exercises about upcoming clinicals and questions you may have, putting together a report sheet, those type of things. So it won't
So
be
we'll-
just lecture.
The day we're not in lab, we'll
Awesome.
do those extra activities.
Yes.
Okay, cool.
Yep. There'll be stuff for you guys to work on. So you'll still want to sign in every day. Always check your announcements. I always post an announcement every day. Make sure you're checking your PIMA email. So like today's humidity brochure.
I think the humidity questions is just an accidental copy of the brochure on Blackboard.
Thank you for saying something. I'll upload that. Let me.
Yeah, it's just the brochure rubric again.
I'm sorry. Okay. So I'll upload that once we get off the call. So did you guys do warm-up questions with Nicole?
No,
No.
not
So
by that name.
It's usually, it's just basic warm-up questions. And if you can answer all of your humidity questions or whatever the topic is, you'll do really well on your MRE. Just a tip. So for humidity brochure, you're assigned a humidifier down here. You can either choose a specific brand, so do some research. Fisher-Paykel, for example, would be a Passover humidifier, or you can make up your own brand and just find other pictures. You can use a template in Word. They have a brochure template. Make sure that if you're using a template though, that you either cover the pictures or that the formatting is right, because those can get a little wonky. You can Google brochure templates online and find a bunch, or you can create your own using a PowerPoint slide, whatever you want to do. You have creative reign on this. Canva.com, you can make all kinds of cool stuff, and they're super easy to use. So you need to describe your device and what it does and how it works. So go into this with the thought that you're trying to sell this humidifier to a hospital. So it's like an advertisement. So describe your device, how it works, why it's the best choice for this hospital over other types of humidifiers, so the advantages. You need to include at least 2 pictures and then give some facts about your humidifier.
Small volume nab's not good enough. Try the large volume nab.
There you go. That could be your pitch. So 14 points for criteria, 5 points for visual appearance and organization. So don't make your print too small that I can't read it, or that funky colors that are really hard to read. And then 4 points for writing level. So this is a level 1 assignment. So basically check your spelling, proofread, make sure you have good grammar, all that fun stuff.
Is this something you want us to present? Is
Nope.
it something, okay, just,
You'll just
and a group project question. Do we all have to turn in our own
yes.
copy of it? Okay.
Oh, well, you. that's a
Or
good
just
point.
turn in one copy with all of our names on it is my question.
Is it
Um,
a group project?
I got to
I
figure
thought
out
we were
how
all
to
doing
do
it.
that.
are separate.
You can, now that you brought that up, if you want to work on it in a group, you can work on it in a group.
Oh, so, okay, never mind then. I just saw the names, so I'll
You're
do my
good.
own.
I
Yeah.
know that clearly. I need to make that clear. So individual, do you guys want to do group projects online for the future? How do you guys feel about group projects online?
I mean, I've liked the ones we've done before, but I'm fine doing solos too.
Okay, well, let's do this one.
Yeah, I think most of it for a lot of us is it's hard to schedule, and the ones that we have to talk with us all spread out and talking
Yeah,
Yeah, not being on campus, having time to work
Yeah,
on
if we
group
had campus
projects.
time that we could at least get together that last hour, that helps. But with us being spread out and all of our
Exactly.
conflicting schedules, it's hard. Yeah.
that's
Because I don't
how
mind
I
them. It's
feel.
just tough.
I agree. Okay, so individual project, I have examples here from former students who have all gotten good grades. So feel free to look at theirs to kind of get an idea. I will switch to humidity questions as soon as we get off this call. Do we have any other questions? Thoughts, concerns? Okay, sounds good. All right, well, I will let you guys go and I will see you on Friday.
Oh yeah, in person.
In
See you then.
person. Bye.
Bye.